Any patient presenting with chronic shortness of breath, either in emergency or OPD, always do echocardiography to rule out the chronic heart failures. Another common illness, patient can present with shortness of breath, pedal edema, fatigue, lethargy, and acutely agitation and worsening shortness of breath. It is defined as heart failure is a clinical syndrome in which either structural or functional abnormalities of the heart impair its ability to fill with or eject blood, resulting in dyspnea, fatigue, and fluid retentions. So, after the establishing diagnosis, do the classification according to New York. According to this, there are 4 classification. Number 1, class 1. If patient has heart failure but normal activity, no limitations due to the symptoms of heart failure, it is the class 1. If there is slight limitation during ordinary physical activity, it is the class 2. If patient has marked limitations and shortness of breath after 20 meter, 20 yard, it is class 3. And if patient has symptoms even at rest, it is the class 4 or severe heart failure. What are the causes of heart failure? Most common cause of heart failure is coronary artery disease. Second is the hypertension, valvular lesion, arrhythmia. There are chronic atrial fibrillation and tachycardia induced cardiomyopathy. These are the common arrhythmias that can cause heart failure. The cardiomyopathies, pericardial diseases, congenital heart lesions, exposure to drugs, chemicals, toxins, and nutritional deficiencies can cause heart failure. During examination, always think about sign of heart failure. What are the signs of heart failure? If patient presented acutely with heart failure, pulmonary edema, patient may be agitated, pale, and there will be the cold extremities. On general physical examination, there will be the tachycardia, pulses, alternance, and blood pressure may be elevated, normal or low. There will be the pedal edema, and saturation may be normal or low. A patient will be the respiratory rate will be raised, GVP will be elevated, and precardium examination there will be the displaced apex beat along with may or may not be murmur of mitral regurgitation or underlying valvular lesions along with S3, S4, S3 gallop rhythm. And on pulmonary examination there will be the basal crepitations. Basal crepitation, gallop rhythm along with displaced apex beat. These are the hallmark of heart failure. Now, how will you investigate a patient with heart failure? Always get the ECG to rule out any ischemic changes, ST segment changes, T wave inversion, R wave progression, Q waves, and rule out any arrhythmias. Do the echocardiography for structural and functional assessment of heart. Pro-BNP is a diagnostic. If less than pro-BNP less than 200, almost heart failure is ruled out. Then do the biochemical profile, especially electrolyte, renal function profile, and do the coronary angiography to to see the cause of heart failure, as the most common cause is the coronary artery disease. If coronary artery disease and functional structural abnormality of the wall motion abnormality of pericardium, then do the stress thallium for reversibility of the ischemia. Sometime for evaluation of the diuretics are to measure the pressure of the pulmonary artery, do the right heart catheterization. Sometime if cardiomyopathy, infiltrative cardiomyopathy, inflammatory myocarditis, and if you are thinking about sarcoidosis, then do the MRI of heart. If all the investigation remain inconclusive, where you are unable to find the cause of heart failure, then do the endomyocardial biopsy. Next, how will you treat the patient? A treatment of the heart failure is start with general measures, lifestyle modification. Ask the patient to do the aerobic exercise as he can perform. Salt and water restrictions. Avoid smoking and alcohol. Advise the patient for influenza and pneumococcal vaccinations. And first of all, symptomatic relief with diuretics. Then give the ACE inhibitor, ARB, beta blocker, along with mineralocorticoid receptor antagonists. These are the spironolactone for acute heart failure. And for same treatment for chronic heart failure, ACE inhibitor or ARB, first line therapy along with beta blocker and mineralocorticoid receptor antagonist. After the follow-up, if patients still have symptoms of class 2 or more, along with reduced ejection fraction 35%, do the electrocardiogram. If patient's heart rate more than 70 and rhythm is sinus, then give the ivabradin 5 mg twice a day. And if QRS complex more than 120 to 150 millisecond on ambulation, then consider for intracardiac defibrillator. And if patient has wide QRS complexes more than 120 along with left bundle branch block, or QRS complexes more than 150 millisecond, then do the RCT. If symptoms of class 3 or 4 with reduced ejection fraction less than 35%, then consider digoxin, hydralazine nitrates, or valsartan with sacubitril. If end stage or advanced heart failure, consider left ventricular assisted device, heart transplant, or both. This is the summary of the heart failure. If patient has heart failure and treatment and increased blood pressure, then add the calcium channel blocker. Devices: ICD, RCT, left ventricular assisted devices, intra-aortic balloon pump if patient has hypotension, and it is a bridging therapy to heart transplant. If patient is diagnosed case of heart failure presenting with worsening of the symptoms, especially shortness of breath, then consider the factors that can worsen the acute heart failures. Most common cause of worsening of heart failure: non-compliant to medicine and diet. 50% patient may fall in this category, and 40% patient may have underlying arrhythmia and superadded infections. 10% may have new onset ischemia. Other causes may have deleterious effect of drugs, NSAID, alcohol, negative inotropics, and may have iatrogenic IV fluids that worsen the heart failure. And there may be anemia can cause worsening of heart failure, and increased demand, especially in pregnancy and thyrotoxicosis. These are the factors that can worsen the heart failures. Thank you very much.